Ah, yeah. Okay. This stage is a final destination
Yeah.
of this World Symposium.
Yes,
Thank you so much for your really nice presentation.
thank you.
Let's all cheer up and make a good recommendation on this stage. Yeah, first, from the first speaker,
Yes.
and Professor Peck, please.
Okay, so it's good to be back on the stage. My take-home message is that implant stability is very crucial, dependent not only insertion torque, but also where the initial stability is derived along the length of the implant. So to successfully achieve anytime loading, safe fixation is crucial due to the significance in terms of the implant, crown to implant ratio. And also, this should be achieved with an insertion torque
Professor
of
Peck,
30 to
Professor
40
Peck,
newton
You can
centimeters.
standing?
Oh, can I stand up? Okay,
No problem.
sure.
Okay.
So your initial stability should be at least 30 newton centimeters to 40 newton centimeters, but it should not exceed 40 newton centimeters because, as I said, it might compress the bone, it can overheat the bone, and we can have some type of bone loss like sulcerization later on. And also the IST value, which is above 70, should be required to enable reliable and durable implant loading. I hope you all learned this, and I hope I'm gonna send the microphone to Doctor for the aesthetic recommendations.
Thank you, Peck. I can rely on what I've already said about my recommendation. Soft tissue is really important to maintain the safety of the implant that we have placed into the bone. So we have, for first, to treat in the correct way the bone, as all the speakers have said in this day. Then, in an immediate load, post-extractive immediate load, where we have to insert the implant in a correct 3D position. Then we must place some bone graft, heterologous bone graft, into the socket between the implant and the buccal bone. Then in the static area, from canine to canine, in my mind, is mandatory to place a connective tissue graft, and then to use a concave transmucosal path of our screw-retained restoration. And I would like to underline that our restoration is out of function, both in static and in dynamic occlusion. And also in delayed load, delayed placement, delayed load, it is mandatory to control the design of our provisional and obviously definitive restoration. And we have the possibility to choose between concave to convex design, and it depends on the thickness of the soft tissue. As the tissues are thick, as we can use convex design to push the tissue in the direction that we want. In every case, it is mandatory and it is very important that we give to the technician all this information, because after 6 months, after 1 year of healing of the soft tissue, the technician must copy our transmucosal design, because if he doesn't copy this design, all the result will fail. And so I believe to have said everything. I pass the microphone to my friend Giuliano.
Can I use this mic? Yes.
Sì, ne avevo due.
So regarding the sinus area, we must focus that we are on the road of 100% success. So the first thing is to understand in which clinical case we are, if we are in class 1, class 2, class 3, or class 4. We must remember that class 1, it is not so easy to be treated, as I told you before, especially if we are in a healed site. Because in a healed site, we do not have the bone lamina, the cortical bone lamina that surround normally the tooth. So if we are performing a post-extractive immediate implant, it will be easier to have success than an immediate provisionalization in a healed site. Because in a healed site, sometimes we have D44 bone quality. And if we are dealing with sinus class 2 or sinus class 3, we can perform immediate loading, anytime loading, but we must keep in mind that we need a special tool that is the S-reamer. The S-reamer is the principal actor, as I have already said, as also Dr. O showed, has just shown to us, because it's a very important burr that is, we can utilize without any damage for the sinus membrane. Sometimes colleagues ask me, why don't you use osteotome? Because it will be easier, it will be quicker than the S-reamer. But we must remember, as I have demonstrated, as I have shown to you, that osteotome not always are predictable in the fracture of the sinus floor. And if you take a look to the literature, the incidence of perforation of the sinus membrane is double with the osteotome compared with the S-reamer. So the S-reamer is also more safety and more predictable. And at the end, if you don't want to run any risk, if you have only 1 or 2 millimeter, go with a crestal approach, but a delayed loading. So submerge the implant and wait at least 4 or 6 months. It depends on the graft material that you have used. I think that those could be the final concept from my lecture. Richard? Yes. Do you want the mic?
Is this okay? Good. Good. So, my topic was successful anytime loading on fully edentulous jaw. So, I make a recommendation to, so one is in a completely edentulous patient with severe bone atrophy, all-on-4 treatment concept in the mandible, and the all-on-6 concept in the maxilla using computer-aided implant surgery with the top-down treatment planning, and the CMI fixation are strongly recommended, especially for elderly disabled patients, to provide enabling immediate chewing function with reduced number of implants and avoiding excessive bone augmentation that increase treatment cost and also the risk for the patient. And secondly, in all-on-X prosthesis, we should highlight the significance of a sufficient anterior posterior spread and tripod and trapezoidal support in withstanding masticatory force in full arch fixed bridges, especially in managing distal anterior cantilevers. Remember this picture here, cantilever, very short cantilever within a 15 millimeters available in this long span bridge. Okay. Next. Dr. Ho, please.
Thank you. Okay. All the speakers talking about anytime loading for all day long. and surprising. We can take the all day long talking about the anytime loading. I think this is the first time here. I'm curious, is this symposium can change your implant treatment? For example, in 1995, I was shocked and changed my life. At the tunnel changed my life from the conventional loading to the immediate loading. So maybe, in the future, everybody can do anytime loading for 5 years later. So if you really want to do that, maybe why not try that step by step? First of all, so somebody who always, anytime submerge your implants, why not try, and placing healing abutment first. Okay, after we get 30 Newton centimeters. But the first time, we try to think, how to manage the bone and how to place the implant, right, for the immediate loading, okay? So we try that first, okay? We show everything for all day long. And then, we non-submerge it. And then check the stability, is changed or not. Okay, if it stay over 70 ISD value or 80 ISD value, why not try the loading in 1 month? Okay, after you get the 100 case of 1 month loading successfully, then you can extend your clinic experience to the more earlier loading, like 3 weeks loading or 2 weeks loading or 1 week loading. Okay, if you fail, then just think again. What's the problem? Because everybody can do this, as I show us. Everything can be done very successfully. So please believe us, in 5 years later, everybody can do anytime loading. Okay? Thank you so much.
Thank you so much, all my respected speakers. And they made a good clinical recommendations after the busy schedule spent 2 days. I summarize everything so that there is clinical issues and also learning objects like this. I make a short summary. The first one, to reach zero failure, we must know the definition of implant failure, success, and survival. And secondly, to judge bone density of implant bed by area and each depth C, N, M, and I, we must evaluate the primary stability both of macro motion and micro motion. And to perform the anytime loading, we must secure the primary stability at 30 to 50 Newton centimeters as insertion torque value, and over 70 as micromotion value, IST or ISQ. Finally, minimally invasive implant surgery and immediate loading for the elderly disabled patient. Thank you so much, my respected speakers. Thank you all.
Thank you to everybody.